This is Neurology Recall, a collection of our most useful, practical, and educational podcasts on a wide variety of topics selected from our neurology podcast collection. Whether you are new to neurology in training or have been practicing for many years, Neurology Recall is designed to help you continue to learn the essentials of neurology, easily, one podcast at a time.
Hi everyone, welcome to the August 2023 Neurology Recall. I'm Jeff Ratliff, Deputy Editor of the podcast. This month's Recall will feature 4 fantastic interviews we've had on the podcast about the topic of functional neurologic disorders. Across all the episodes, you'll hear Dr. Jon Stone as the interviewer with various other experts in this field. The first 2 interviews are on the topic of functional tic-like episodes. The first interview was a joint interview with Jon interviewing Dr. Tamara Pringsheim and Wall Street Journal columnist Julie Jargon. That interview aired January 27 of 2022. That topic of functional tic-like movements was followed up just over a year later on April 20 of 2023, in which Jon interviewed Dr. Pringsheim again, along with Dr. Davide Martino, about functional tics, as well as new diagnostic criteria which had been developed. The recall then shifts to 2 interviews on the impact of functional neurologic disorders on the economics of the healthcare system. On January 16, 2023, Jon spoke with Dr. Tjerk Lagrand about the healthcare utilization of functional neurologic disorders and how the explanation of the diagnosis of functional seizures can impact healthcare costs. The last interview on this month's Neurology Recall originally aired on June 22, 2023, in which Jon spoke with Dr. Mahinda Yogarajah. In that interview, Dr. Yogarajah discussed the importance of appropriate diagnosis in FND, as well as overall use of healthcare resources surrounding patients with functional neurologic disorders. We hope these interviews will help us all better understand the evolving landscape of functional disorders as well as their economic impacts. Thanks for listening to this month's Neurology Recall. We'll see you next month.
This is Jose Marino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Welcome to this Neurology podcast. My name is Jon Stone. I'm a neurologist in Edinburgh. And it's a great pleasure today to be having a discussion with 2 colleagues about rapid onset functional tic-like behaviours, functional tics. You may have seen a number of papers about this. And I've got with me today Tamara Pringsheim, who's a neurologist from Calgary in Canada, and also Julie Jargon, who's a journalist who wrote a very widely shared article in the Wall Street Journal about this topic. So welcome to Tamara and Julie. Tamara, I wonder if we could start with you first. You published a paper in Movement Disorders earlier in the year. The paper was Rapid Onset Functional Tic-like Behaviours in Young Females During the COVID-19 Pandemic. So I wonder if you could just tell us a bit about yourself and how you came to this topic.
Sure. Well, I'm a neurologist specializing in Tourette syndrome, and I've been running a Tourette syndrome clinic for the past 14 years, the only Tourette syndrome clinic in the province of Alberta in Canada. We became interested in this topic when, in the fall of 2020, we started seeing a number of young people who developed the sudden and rapid onset of functional tic-like behaviors. And this was quite unusual. Certainly in my clinical practice over the past many years, we would occasionally see people with functional tic-like behaviors. I would say maybe 1 or 2 per year. But over the course of a few months, we saw dozens of people, which led us to know that there was something different happening. At first, we thought that we were alone, that we were the only center seeing young people with functional tics. I was alerted on the Synapse chat on Neurology. There's a movement disorders group, and somebody put a post, is anybody else seeing a lot of young people who have suddenly developed tics? And many of my colleagues responded that they were also having this experience. And it was then that a bunch of colleagues from different centers came together to initiate a formal study of this phenomenon.
And Tamara, with the patients that you were seeing, did they have something that looked like previous patients you'd met with functional tics, or do you think you were seeing something that was different even to previous patients with functional tics you'd seen?
Yeah, so I think the really striking thing was the commonality in symptoms between patients. So, we were seeing people who didn't know each other, who were from different parts of the province, different parts of the city, who were manifesting the same types of tic-like behaviors. I'll give you an example. So in the course of 1 week, I saw 10 different people who were all clapping, whistling, clicking, popping, saying the same words like knock, knock, woohoo, beans, who were throwing objects, who were hitting themselves in the thighs or hitting parents. And when you see so many people with the exact same tics in a short period of time, it really suggested to me that there was a common model for these tic-like behaviors. In years past, when I saw people with some functional tics, they were always very different from one another. So it was really that, these complex behaviors evolved over a period of hours to days and became very severe in a short period of time that separated them from functional tic-like behaviors that I saw in years past.
I guess it might be helpful for listeners as well who perhaps don't. I mean, functional tics was very much the sort of small print of FND until a couple of years ago.
Yes.
I mean, I'd seen
yes.
a few, saw 1 or 2 patients a year. I mean, just for listeners of this podcast, what sort of things would you be looking for to tell the difference between a tic that's part of a functional disorder versus Tourette's, for example? Obviously, there are other causes of tics, but that's the most common one.
Sudden onset is a clue. Tic disorders like Tourette syndrome usually begins quite insidiously, in young children. So, my typical patient is a 6-year-old boy who, has started blinking. And the blinking lasts for a few months. It disappears over a few week period, and then they develop a different tic, typically, throat clearing or sniffing. And then that goes away, and then they develop another tic. So in early childhood, what we typically see is sort of one tic at a time that comes and goes. And then typically between 10 and 12, they may have several tics at the same time, and the tics may start to become more complex. Children it usually always starts with tics of the face, and then over a period of years, they migrate caudally. So there's this rostrocaudal progression of symptoms. Usually motor tics start before vocal tics, and on average it's motor tics first, and then after maybe about a year developing simple vocal tics, and then in late adolescence typically symptoms improve, and in a significant portion of young people their tics either are completely resolved or much better by the time they reach late adolescence. So that's the typical sort of life history of tics. We suspect a functional tic disorder when there's a sudden onset, when there's a lot of complex vocal tics in the absence of simple motor or vocal tics, when there's no family history, for example, or typical comorbidity, and when there's a lack of response to the typical treatments that we use to help with tics. Those would all sort of be a clue that this could be a functional tic
One
disorder.
of the things I've heard, or one of the concerns that's been raised with me, is this very striking difference in the gender and age of onset in patients with both functional tics and functional tic-like behaviours, and that we're seeing predominantly female versus predominantly male in Tourette's, but one of the concerns raised with me is, well, are we missing Tourette's in women, in girls, in younger girls? Do they present differently? Is there, have we been confusing those two things, or is that confounding some of these presentations? I wonder what your thoughts were about that.
We've actually done research in this area. We started looking at this actually before the pandemic, since we have here in Calgary, we have a large tic disorders clinical registry. And so we had the ability to compare the clinical presentation of children with Tourette syndrome by sex. Again, this is data that I collected before the pandemic, and it's a large sample of children. When we look at sex distribution, it is 80% males, 20% females. But if you look at the 20% of females, the age of onset is identical to males. So the mean age of onset of tic symptoms in girls is 6, and it's also 6 in boys with Tourette syndrome. The mean age of clinical presentation, so when they finally get to a specialist clinic, also was the same. It was 10 years in both groups. We found one difference between males and females with Tourette syndrome, and that was that there was a small but significant difference in tic severity between boys and girls, with girls having slightly higher tic severity, not dramatically, but it was statistically significant. And the tics tend to persist more in girls than in boys. There's higher resolution of symptoms in late teens in boys compared to girls. But in terms of the phenomenology, the onset, the peak in age of presentation, these characteristics are very similar between boys and girls. And so I really don't think that we've been missing it all these years. And when I look at the research that's been going on in Tourette syndrome, over the past 50 years, while there is a definite bias in all of our samples towards males, female patients have definitely been included in that research, I don't think that we've been ignoring or marginalizing the female population with Tourette.
Briefly, what do you think what proportion of patients that you're seeing with these rapid onset functional tic-like behaviors do you think also might have mild Tourette's, or perhaps just a more simple tic disorder as well?
I'd say probably 10 to 15% of the people that we're seeing have a history of simple motor or vocal tics in childhood. But interestingly, the presentation has been identical. So they've developed the same types of rapid onset functional tic-like behaviors as the young people with no history of tics.
And I see from your paper, you brought together data from your own centre, colleagues in Sydney,
Yes.
London, and Cincinnati and UCLA. I mean, just you give listeners some idea of the change in referral patterns pre and post pandemic.
In all of our centers, there was an increase in the proportion of functional tic-like behaviors seen during this period, right? Where, for many of us, we are seeing, 10 to 20 times the number of cases of functional tics compared to before the pandemic started.
I mean, did it start on the nose with the pandemic, or or was it just before, or just after, or?
Well, it's interesting because in some places it started before the pandemic. And so if you look at the work of Kirsten Muller-Wahl, who is, a leading international figure in Tourette syndrome. She's devoted her career to the treatment and study of people with Tourette syndrome. She started seeing cases in 2019. And she wrote a paper about this in Brain. And in the German context, it seemed to correlate with a popular German YouTuber. I think he's the most popular YouTuber in Germany. He has the most subscribers to his channel. And she started seeing a number of people who had identical tics to this very popular social media personality. So I think that's very interesting that the pandemic was not a necessary ingredient for this increase in functional tic-like behaviors.
And there's been other centres, haven't there, and particularly in Houston, have reported case series, and there's been some others as well around the world. So, as you say, it's not an isolate. It's not just certain centres. It's sort of everybody noticing the same thing.
There's been case series published, Alexander Munchow, also in Germany, Merit Parnes and Miriam Hull in Texas, Tammy Hedderly in London, and speaking with my colleagues, Don Gilbert in Cincinnati and Russell Dale in Sydney as well. And I can tell you that I've heard from people from all over the world. I get emails probably 2 or 3 days a week from people from everywhere, from every continent, I think so far except Asia and Africa. I've heard from people who have developed these symptoms and who are looking for help.
That's a good time to move on to speak to Julie Jargon, a journalist, The Wall Street Journal. Julie, because you wrote this article which came out in October, I think really in response to this obvious story that there was something new going on here. How did you first come across the story?
I was actually interviewing a teenager for a different column entirely, and after that published, I heard from her father. We were just exchanging some emails about that column, and he said that he had been longtime family friends with this family in Texas, and he had recently seen them and their daughter, who's 17, and he noticed, and the parents talked about how distressing this was, that this teenager had suddenly developed these tic-like behaviors, and they didn't initially understand what this was all about, what was going on. And he said that there was some mention of a potential relationship to TikTok videos. And he said, might be something you want to look into. And I was intrigued. I had no idea what this meant. I ended up, before I even talked to the family, I just did some online research, and I found, all of these papers, this research that has been done. And I started reaching out to some different doctors, in throughout the United States to find out what they were seeing. And I was hearing these stories of, just as Tamara described, of these, teenage girls largely who had been coming to these different specialists with these tic-like behaviors. And, that doctors were finding out that these new sudden onset cases were all very similar in nature to each other. And that one of the things a lot of these young people had in common was that they had been watching a lot of TikTok videos of people on TikTok who had very similar types of tics. So I just was interviewing more and more people. I ended up interviewing this family about what they had experienced, and that led to this story.
So I'm interested in your perspective as a journalist. So obviously not from within neurology, but coming from outside of it. What about these young people and families that you met and the impact of these symptoms on them. I was wondering what your experience was there.
Yeah, well, I think that, the families at first, in particular this family that I featured in the story, they were just desperate to find answers. They, had seen a number of different doctors. It takes a while to sometimes get to the right doctor, to get the right referral. Doctors are busy, their practices are full. It can take months sometimes to get in to see a specialist. So this young woman, when she finally went in to see a specialist at Texas Children's Hospital, they had already seen a number of cases like hers, and they started asking her about her social media use. And she, even though she didn't think about it at the time as being a potential factor in her onset of functional tics, she described how she had gone to YouTube to find videos of other students like her who were struggling with remote school, who had ADHD, and she stumbled upon TikTok compilation videos of people who were exhibiting functional tics, and she watched a series of these videos over and over again, and that kind of lit a kind of a bulb in her to think that maybe there was a connection there, and so that was a commonality that I learned among a lot of teenagers, especially during the pandemic. I think some of the confounding factors were the pandemic created a lot of stress and uncertainty for a lot of people, a lot of young people that already had prior diagnoses of anxiety or depression. Perhaps they were more susceptible to things. And, as we all know now, screen time usage just skyrocketed during the pandemic with kids at home and not a whole lot else to do. They turned to social media, and TikTok in particular. TikTok overtook Google as the most visited website in 2021, just to give you an idea of the scope and the popularity of TikTok just during the last, year or so. So that was surprising to me that, I cover tech and I cover the impact that technology is having on young people, in large part as part of my column. So this was really fascinating to me to learn that there could be some unifying element in all of these young people who didn't know each other and yet were saying some of the same words with their vocal tics and exhibiting some of the same motor tics as people, on the other side of the world, the other side of the country, who they had never met before.
I'm going to bring in Tamara again as well here, because one of the things that I've noticed in the patients I've met, and when I've asked about social media use and TikTok, is that, some of them said they absolutely had not seen any videos, they just weren't watching them. Some of them had said, well, I'd started to get tics, and so that's why I was watching videos of other people with tics to find out more about them. I wondered what your feel was, Tamara, and maybe Julie as well, about how often people said that they didn't have any tics and they felt that the tics had begun after watching people with tics, or whether the tics started before they started watching.
In my experience, most of the patients have reported seeing the videos prior to the onset of their tics. There are a few who say that this was not a factor, but I'd say the majority report exposure. And some, they're very forthcoming about it. I had one person tell me that the night before it started, they were up the entire night watching TikTok, watching videos of people with tics on TikTok, and this started the very next day. I have other people who say that they have that their best friend develops sudden onset tics, and after spending the day with their friend, that they develop these tic-like behaviors. I think the really important thing is that exposure to the videos on social media is not sufficient or necessary to cause patients to develop these functional neurological symptoms. There's always a bigger picture. Millions of people have watched these videos and never developed tics. So this tells us that there are certain individuals who are susceptible to developing these tic-like behaviors after seeing the videos. And typically it's people who are experiencing significant distress. Many of the young people that I've spoken to have talked about the major losses they've experienced over the course of the pandemic. Young people who were busy athletes, who were busy musicians, or who had very active and fulfilling social lives, and everything came to this crashing halt when the pandemic started. And the profound loneliness that they've experienced as a result of physical distancing, not attending school. People have talked to me about the anxiety they experienced waiting in their classroom for their names to be called as a close contact and having to go home. I think that the pandemic has really had a profound effect on young people. It's been deeply distressing. It's exposed the uncertainty that all of us face. And that's the uncertainty we all face is part of life. That hasn't changed. But I think the pandemic has made people confront the uncertainty of life in a way that's been quite painful for many people.
My experience as well of the patients I've met. So, Julie, do you think that with the patients you've come across and interviewed, one of the very difficult things about this whole area is this idea that we've seen headlines about TikTok tics and ways that sometimes when people have described it, I would say definitely not in your article, but in some other locations where people are perhaps not trivializing the problem, but perhaps reducing it a bit too much and simplifying it as, it's just social media has caused this problem. The solution is, well, just stop watching TikTok and you'll be fine. I mean, we've just heard from Tamara very eloquently why many of these people are not fine in other ways, and that's my experience too. I wondered what your experience was of how the patients feel about this relationship being raised between TikTok and their condition.
I have seen some coverage of people who have been diagnosed with Tourette syndrome who feel that perhaps their condition has been trivialized, or that people might feel that they're faking it. And I think it's important to distinguish here that in my article and what I've been hearing from all of these doctors is they're not even talking about Tourette syndrome here. We're talking about functional neurological disorders. However, there have been some people on TikTok who use the hashtag Tourette syndrome and say that they have Tourette syndrome. And it's unclear whether they do or not. But I think there's a feeling that among a community of people on social media, they've made great strides to remove the stigma of Tourette syndrome and having tics, and just showing, being very open about their condition, which is generally a very good thing. However, the fact that so many young people have developed these sudden tic-like behaviors has been problematic for a lot of families and created a lot of distress. And so unfortunately, I think there's some people who feel like that has been a negative for them, for the people that do have Tourette and feel like they have made great strides to destigmatize the condition and be open about it, to now feel like maybe people are second guessing them and not believing that their diagnosis is real. That's unfortunate that has happened, or that people feel that the strides that they've made in destigmatizing a condition have kind of come back to bite them in some way.
I guess I would add, Julie, from that point of view, that it's exactly the same issue for people with FND who've got people who do have functional tics, because we're talking here about for patients who do have a functional tic disorder of some kind, that they have got a genuine disorder, and so I think they also would experience the same degree of stigma again, of feeling if someone's pointing to one particular risk factor like TikTok and saying, well, that's why you've got that symptom. You better stop doing it. But as we've heard, it's a lot more than that. So I think getting across these nuances is very difficult, isn't it? And even getting across the idea that there's Tourette's and there's another disorder is very difficult for people. They just think about tics.
Yeah, I think it can be very confusing. And I also just want to say that, there are a lot of people who, read this article and seen themselves or their families in it and have, felt very grateful that they now know that they're not alone, and that they know there might be some reasons behind why their teenager suddenly started exhibiting these tics, and now they have some resources and they know that they need to turn to a specialist to get a diagnosis, and that there is help and hope for people who have developed these tics. There are treatment options for them, and they're very much not alone. I think the family that I profiled, they really, as they sought answers over the course of many months, they said that it felt like a very lonely process. They didn't know any other families like them that were dealing with this. They had no answers, solid answers, as to what was underlying their daughter's sudden display of tics. And so, I think the flip side is that this has brought a lot of awareness to, there's something going on here. There may be multiple factors for each individual child, but it doesn't have to be a lonely feeling. There are a lot of people in the same boat that have experienced these sudden tic-like behaviors.
Absolutely. We've seen a similar phenomenon in the FND community generally, with people being able to connect and recognize that other people have the same experience. But you've introduced treatment there. Tamara, what's your experience of treatment for the patients you've seen with these with the rapid onset tic-like behaviors that you've described?
We've just finished a 6-month follow-up study of the first 29 people that we published the case series about. So 20 adolescents and 9 adults. We've seen many more. We've probably seen 100 patients with this disorder since this all began. But looking at the follow-ups of the originally reported cases, everyone is better. It's not resolved in everybody, but everyone has made some improvements. When we look at their Yale Global Tic Severity Scale, that's a measure that we use in Tourette syndrome, where we go through a tic inventory and then a measure of sort of tic frequency, severity, interference, impairment, etc. The adolescents have improved more than the adults. And quite a bit more than the adults. And you're the FND expert, but I think that the same can be said in most other functional neurological disorders, that the prognosis is better in children compared to adults.
As well as having tics, go on to develop more clear-cut FND symptoms like seizures and tremor and paralysis.
Yes. So 4 of our 29 have developed functional seizures since in the past 6 months, since we saw them the first time. I'd say that the treatments that, again, this is a small sample. This is only 29 people, but I'd say that if I look at the people who have a score of 0 on their Yale, so they have no tic symptoms whatsoever, the common treatments that they're on are selective serotonin reuptake inhibitors and cognitive behavioral therapy for anxiety and depression. Those are the treatments that I think work the best. And so, I haven't been using medication for tics in this sample. I've been using antidepressants, typically sertraline, and having them attend cognitive behavioral therapy for anxiety and depression symptoms. And it's been so interesting to me to talking to these patients after like in follow-up, and just the emotional growth and insight they've developed about their condition over the course of that journey. And, sometimes it was only when the symptoms resolved that they were able to say, I was so lonely. I was so isolated, and being part of a group therapy for depression and anxiety gave me that community that I was looking for and craving, and this really helped me. This helped me get over my symptoms. Like this helped my symptoms resolve. And other people saying, my parents got divorced and I was devastated, but I couldn't say that, right? I couldn't say that to my parents. I didn't want them to feel guilty about what happened. But, through the therapy, I'm dealing with that head on, and my tic symptoms have disappeared. So there's, been really profound growth and resilience through getting the help that the kids need, that the young people need. So
I think there's an
I really want
message there,
people to be hopeful.
This isn't just about recognizing things that are not Tourette's, it's about recognizing a disorder which does have a potential, that has a treatment attached to it, which can benefit many patients with those symptoms, and they are having genuine symptoms and distress. That's been a really interesting discussion with you both. Thank you so much for speaking with me today about this. I think it's a sensitive and sometimes difficult topic to get across, and I think hopefully we've done that today. And you can certainly read more about this in Dr. Pringsheim's article, Julie's article in the Wall Street Journal. There's a page on functional tics to the website that I've made for people with FND that you might find useful as well. So, and thanks for listening, and have a great week. Welcome to this episode of the Neurology podcast. My name's Jon Stone. I'm a neurologist in Edinburgh in the UK, and I'm really delighted to have with me today Davide, Martino and Tamara Pringsheim to give us an update on where we are with functional tic-like behaviours, functional tics. I did a podcast with Tamara just over a year ago, and since then there's been a lot of activity, information. Many of you may have seen an article from the New York Times a couple of months ago in February 23, talking about what's happening with functional tics. So, Davide, Tamara, welcome to this podcast.
Thank you.
Thank you.
Maybe we could just start by letting us know a bit about yourselves and the roles that you have.
Davide Martino. I'm a professor of neurology at the University of Calgary, and I am also the director of the Adult Movement Disorders program.
Great. And Tamara?
I'm Tamara Pringsheim. I'm a professor of neurology at the University of Calgary. I run the Tourette Syndrome Clinic at the Children's Hospital, and I also see adults with Tourette Syndrome Clinic at our Movement Disorders Clinic.
We're going to cover a few different things today. We want to talk about the topic of the New York Times article, which was really sort of suggesting that maybe a lot of patients with functional tics had improved and perhaps the problem's going away. But things are never that simple. And both of you have been involved in some really helpful, important papers, I think, looking at the clinical details of patients with functional tic-like behavior and also suggesting new diagnostic criteria for them. So we're going to cover all that. But I wonder if we could start with just a recap here for those who've perhaps not up to date with this story. What's happened with functional tics in the last few years? Because those of us that were involved in tics and movement disorders and functional disorders saw the occasional patient with functional tics, but something unusual happened in the last few years.
Things started to change in the fall of 2020. We were in the midst of the COVID-19 pandemic, and simply we started experiencing the admission of patients with a very abrupt and almost explosive outburst of repetitive behaviors that really looked like complex tics. Admission to emergency departments or very fast, streamlined referrals to our movement disorders and Tourette clinic. And we started observing this, as I mentioned, for the first time around October 2020, but then they started trickling in for the following couple of months, and then really the situation exploded a bit the first couple of months of 2021. to the point that our ratio between traditional primary tic disorders and these rapid onset tic behaviors in terms of new referrals came almost reversed. I mean, we were seeing almost more new patients that we were labeling as functional compared to primary tic disorders, whereas in the past, really, the functional patients really explained or less than 5% of our, if not even less, 3% of our new referral population. And we started chatting, obviously, with our colleagues around the world who see patients, primarily patients with Tourette, and have an interest in that. And we just realized very quickly that this was something that was happening really around the world and not just in our center. And then there was an editorial published from London, from Tammy Hatherley and Isabel Heyman, was probably the first publication that highlighted this. And it became very clear that we needed to compare our experiences and trying to figure out what was going on.
And I think you've put together this paper, which appeared in the European Journal of Neurology, from your international registry, from all these colleagues around the world. Tamara, I don't know if do you want to come in here and just tell us a bit about that collaboration and where that now sits in terms of the data that we have on these patients?
Yeah, so people had been publishing their individual case series from different centers, and we thought it would be useful to have the information all together and to perform some common analyses. And so Davide led the development of this international registry where we were able to describe several hundred patients who developed functional tic-like behaviors from 2019 and describe the common characteristics seen in this sample.
So this is now really the largest sample, isn't it? The largest group of, sort of clinical description in terms of what we've known, what we've learned about this type of movement disorder.
Yes, there's almost 300 patients in the international registry that were included.
Whereas I think before the pandemic, I think there was just 2 or maybe 3 small case series of 10 or 20 patients.
That's right.
Which gives some idea of the difference in terms of the numbers. So a lot of patients. Some people have talked about sort of epidemic. Do you think that is a useful word, or is that exaggerating it in terms of the overall numbers that people have seen around the world?
I don't think it's an exaggeration, because since that time, a number of papers, population-based studies in both the United Kingdom and the United States have actually documented a rise in visits to general practitioners and emergency rooms for tics, and specifically tics in teenage girls. So we know that it occurred widely across populations. So it's not just something that was seen in specialty centers. It was seen in the general population.
So you think there's a lot of patients out there with tics not making it into these specialist clinics?
I think that we only saw the tip of the iceberg.
Yeah, interesting. One of the reasons this became so well known was the media got hold of this concept that social media had potentially been a powerful factor in this explosion of new cases, and then acquired this name TikTok tics. Perhaps I can ask your thoughts on that now that we're a few years into it. What do you think about the role of social media? Should we be calling them TikTok tics?
Certainly, we're looking for catchy denominations, and personally, I'm not a great fan of catchy denominations in medicine. But certainly, what we have observed is there was a significant proportion of these young people who manifested complex tics that could be related almost in a sort of a modeling scheme to tic behaviors. I think we could probably call them tics just to make it simpler and faster, but tics that were exhibited by highly popular influencers on different social media, not just TikTok, obviously. I think it's obviously focusing on TikTok because it's important and because it sounds like tics, but actually probably some of the most interesting videos from these influencers were actually published on YouTube and other social media channels too. So there was certainly, for a proportion of these patients, a modeling scheme that was happening. Some of these complex vocalizations have really kind of made the news for how commonly spread they were in an unprecedented way, like the word beans, or there are other examples of behaviors that appeared very context appropriate sometimes, which is not a characteristic of primary tics. And it was actually talking to Tamara talking to a member of her family, a daughter who was obviously more acquainted than us on what was going on the social media world, and realized that we actually found some of these influencers. And then there was also a homologue, if you will, in the German world, in the Germanophonic world, who had been active even before the pandemic, and which led also to some important commentaries on this by Kirsten Müller-Wald's team in Hanover. So it is certainly true that there's a modeling element in the proportion of these patients. Whether that explains at all, obviously, it is quite unlikely that this is the explanation for the phenomenon that we have observed. I also think that the time period is quite important, and the effects of the pandemic were temporally coinciding with the explosion of these social media influencers. They were happening at the same time, probably facilitated by the different use of social media that occurred during the pandemic.
If I might add that, one thing that's really striking me now is that currently there seems to be an increase in social media sort of chatter about borderline personality disorder, autism, and ADHD. And now many of my patients who originally presented with tics, their tics have remitted, and now they're seeking diagnoses of ADHD, autism, or borderline personality. So it seems that, there are trends on TikTok, and certain things rise and fall in popularity. And I found that the clinical presentations I'm seeing are sort of paralleling the rise and fall of trends on social media.
So I know that patients themselves, I think this is probably an important point, are very unhappy with the idea of TikTok tics, both patients with functional tics, because it tends to suggest, well, you've just been looking at social media too much, just stop it. And also I know that a lot of patients with Tourette syndrome, particularly girls with Tourette syndrome, were being told that they had Tourette's because they were looking at social media too much. So it's had quite a lot of adverse consequences for patients as well. I don't know if you found that. And we should probably try and avoid talking about TikTok tics, is my personal view.
I think that it's gone both ways. In some people, they found that when they decreased their exposure to such stimuli, that their problems improved greatly. Some of my patients were very forthcoming about the fact that, they'd spent the entire night watching these videos and came down with symptoms the next day. And some of them, even before meeting with us, realized that this was triggering their own behaviors and deleted the app from their phone. So I think it really depends on how open someone is to the possibility that they are being socially influenced. We are social creatures. Our behavior is affected by the behavior of people around us. We are impressionable. And I think that the acceptance level of this fact differs from person to person.
Makes sense. And you said there, Tamara, how so many of your patients, tics have improved, and now they're talking about other things. What are your thoughts about the frequency of functional tics now compared to, say, a year ago, 18 months ago?
It's definitely come down. As Davide mentioned, there was a time, I'd say, for most of the second half of 2021 and the first half of 2022, in my clinic, we see 6 new patients a week. And easily 5 out of 6 of those patients were patients with functional tics. And now probably I'm seeing maybe 1 new patient a week with functional tics. And again, most of my patients have Tourette syndrome. It hasn't come down to the proportion of functional tics that we saw prior to the pandemic, but it's dropped significantly. That could be because now the pediatricians are aware of functional tics and they're not referring them. I think that that's possible. But I also think that it's naturally just improving. Most of our patients are improving, not all. There are some that continue to have functional tics, but we just performed an analysis of our data of a prospective follow-up of patients, of more than 80 patients over 12 months. And there's a major decrease in the number of tics patients have, the frequency and severity of their tics, and tic-related impairment over time. So we know that patients are recovering from this.
That mirrors my experience here in Scotland as well. I think there has been a gradual decrease as well. Although, as you say, it's still there. more than it used to be.
Yes. I found that some of my most severe patients are now developing other neurological or psychiatric symptoms or questioning other neurological or psychiatric diagnoses. I've had a number of patients develop functional seizures, some functional fainting spells, functional paralysis, and then again, a number seeing psychiatrists for questioning diagnosis of autism, ADHD, or borderline personality.
Well, let's talk a bit about that, because, the link with other FND symptoms was pretty clear early on, wasn't it? That was one of the things that these patients had in common. But I think all of us working in the field of FND are becoming more and more aware of this sort of autism, ADHD, borderline personality, or emotional instability, it's sometimes called, personality traits. And as you say, that what's happening is they're becoming something that people actually are actively seeking. We have to be careful here, don't we? Because we've got 3 neurologists talking about this, but you, as tic experts, would be very familiar with neurodevelopmental issues as well. What do you think about some people I'm talking to are feeling that perhaps rates of autism spectrum disorder are actually very high in this group, and perhaps in FND generally?
Yes, I believe we generally agree with this statement. I also think that as everything, we need to be very accurate in the way we screen and assess for these comorbidities. And so some centers might have observed this more clearly also for the characteristics of their assessment procedures, and others might have not captured this as profoundly, again, for some discrepancies and differences in the way in which, for example, autism is assessed. But this is definitely what the data seem to show. Whereas in primary tic disorders like Tourette syndrome, ADHD and OCD are by far the most important and in prevalence neurodevelopmental comorbidity. In this population, autism is probably the prominent one. We see certainly less ADHD and OCD than we would see in a population of patients with Tourette syndrome. As far as the awareness of patients about this comorbidity, and I think the very interesting phenomenon that Tamara was alluding to of diagnosis seeking, this actually seems to be an interesting common trait within this population. And I don't know how much this applies to the overall FND population, but it is certainly a very interesting phenomenon that we are observing, and that probably relates to other psychiatric domains or personality traits.
Do you have any thoughts, either of you, about if there is a real association between autism spectrum and FND and functional tics? Any thoughts about why that might be?
I don't know that it's autism per se versus autistic traits, right?
Yep.
In my clinical assessment of patients, I found that they wouldn't meet the diagnostic criteria for autism as they currently stand, but that a number of these patients had a lot of social anxiety and perhaps, had difficulties forming social relationships with people, as well as an insecure development of self-identity. So I think that the research will head in that direction. We've tried to delve more into this through one of our ongoing research studies, and I think there'll be more to come.
Yeah, I agree. And it's difficult, isn't it, when social anxiety overlaps with autism? They do share some common features as well as important differences, yeah. I wonder if we can come on to the second study, also published in the European Journal of Neurology. I think, Tamara, you were lead author on this, and Davide, you were last, which is the opposite to the other study. I found this a really helpful paper because what you've done is you've got together a lot of tic experts, 24 members, did a sort of Delphi process and came up with some diagnostic criteria for functional tics or functional tic-like behaviours. And I wondered if we could just take the listeners through that, because I think there's some really important lessons here about what things that we think are more specific to functional tics and which ones perhaps are less so.
We used a very data-driven approach based on the international registry was certainly very helpful, but then also looking at the individual case reports and as well as our own registry here in Calgary, and then comparing it to registry data on patients with Tourette syndrome. And so, we've proposed 3 major criteria that help clinicians differentiate functional tic-like behaviors from tics, and then two minor criteria that differ in prevalence between the two conditions, but don't differentiate functional tic-like behaviors from tics. And so our major criterion were the age at symptom onset, the rapid evolution of symptoms and phenomenology, and our minor criteria were the comorbidity profile and the presence of other functional neurological symptoms or somatic symptom disorders. Age seemed to be very important. The vast majority of patients with Tourette syndrome and chronic tic disorders present early in life, usually before the age of 10. More than 90% before the age of 10 will have a symptom onset. And this is very different from functional tic-like behaviors where, by and large, patients were 12 years and older. I mean, there were a few that were a little bit younger than that, but again, more than 90% were over the age of 12 at the time they developed symptoms. So we felt that this was a good number to use as a proposed cutoff that was highly suggestive of functional tic-like behaviors.
Presumably, it's very rare for you to meet someone whose Tourette syndrome has genuinely started after the age of 12.
We have a tic disorders registry in children here. We have almost 300 patients in our registry, and more than 90% report a symptom onset before the age of 12. And usually, the mean onset is at the age of 6, right? So it's considerably lower. And the 95% confidence interval is quite narrow around that onset. Not only shown this in our registry that we're collecting right now, but also in established registries that were collected many years ago. So there's an international registry by Roger Freeman, which includes several thousand patients with tic disorders. And again, more than 90% of patients had a symptom onset before the age of 10.
So we've got the age, we've got the rapid onset, which is quite typical of many patients with this, but very unusual for Tourette's.
Exactly.
And then the phenomenology. I'm sure the listeners will want to hear about what are the clinical clues to the actual features of the tics themselves, or tic-like behaviors that we should be looking for.
The most striking clue is the relationship between simple and complex behaviors, which is, again, temporarily almost reversed in this population. In Tourette syndrome, kids go through a phase in which they predominantly manifest simple tics, both motor and vocal and phonic. Typically, the motor start earlier than the phonic, a little bit earlier. They maintain this simple nature of very limited number of muscles being involved. There are small movements. And then further on in their natural history, some complex behaviors that share the same basic characteristics of the simple tics, suppressibility, the association with the premonitory urges, they ensue. In this population of functional tics, what we found was, what was observed is that these complex behaviors were essentially present since the offset. As soon as these behaviors started, they had a degree of complexity that was unprecedented in the field of tics. And they were both movements and complex, elaborate vocalizations, which were not so much meaningless sounds, mostly produced by the upper respiratory tract, like sniffing or throat clearing and so on, but really linguistic, verbal tics, fragments of language, meaningless alliteration of sounds and syllables, or words that seemed, in many cases, nonsensical as well, which is also quite unusual in the field of Tourette. The motor complex tics were quite violent and quite ballistic in their phenomenology, and sometimes even implied an interaction with the surrounding environment or themselves, like hitting, for example, or touching or hitting forcefully a surface or another person or oneself was pretty commonly observed in these patients, and pretty much from the get-go or very soon. So this is one of the keys of the phenomenological differences between primary tic disorders and these functional tics is really along the dimension of the complexity and how representative complex tics are of this particular diagnosis.
So higher complexity, lots of words and statements, not just vocalizations. But quite early on, people had been suggesting as well that tics that interfered with normal movement were quite common in functional tics, quite rare in Tourette's. That didn't make the diagnostic criteria in the end, I think.
No, we talked about people having context-dependent tics. So, throwing objects in the direction of people, making statements that seem directed at others or based on the situation. But we didn't talk about it interfering with activities. We did talk about how typically during the neurological exam in the patient with Tourette syndrome, the tics are noticeably less. Like when I'm doing finger nose or eye movements, often in my patients with Tourette's, their tics are completely suppressed. But in this population, that the functional tic-like behaviors were often dramatically worse during the neurological exam.
I mean, it fits with many forms of FND that are states of abnormal focused attention. Obviously, we should emphasize these are involuntary symptoms. People aren't doing this on purpose. But yeah, I think that's a very common feature of other functional movement disorders, isn't it? Mm-hmm. And I also was going to ask about ability to suppress tics, because again, that was a feature that people had said early on, and I wasn't sure about that because I felt I was meeting a lot of people with functional tics who were telling me that they could sometimes suppress their tics in the same way as Tourette's. And I was interested that didn't make it in either.
I found that highly variable between patients. It was really about 50-50 for me. About half of them would say, yeah, I can suppress it, and others would say it was completely involuntary. So we didn't feel that it was reliable enough to differentiate tics from functional tics.
And then just moving on, so we've got the major criteria, which really are about the onset and the nature of the tics and the age of the person. It's not about the person themselves or what other medical or psychiatric history they've got, which I think is a very important message. But you did add some minor criteria just to emphasize the importance of looking for that comorbidity.
Yes, it was quite striking, the difference in prevalence of the functional or somatic symptom disorders in this population compared to our patients with Tourette syndrome. And then also just that it seemed that depression and anxiety symptoms, self-harm behaviors, and difficulties with social relationships were the most common comorbidities in this population compared to ADHD and OCD in our Tourette patients.
Great. Yeah, I thought it was a very nice way of handling that issue. So perhaps we could just finish off with some thoughts about treatment. I mean, you've said a lot of your patients have improved. Do you think that has been the treatment, or do you think that this is often a self-limiting problem anyway? What kind of advice would you give to neurologists out there listening who perhaps don't have access to sort of highly trained tic therapists to help them with their patients in terms of treatment?
Our approach here was to address comorbidity if we could identify a comorbid condition to, if the patient had an underlying anxiety or disorder or major depressive disorder, was to treat this. But we also felt that the functional behavioral intervention and assessment were very important. We needed to understand what the antecedents and consequences of functional tic-like behaviors were for individual patients and to help them to develop coping strategies, and that this certainly was helpful in bringing about resolution. I wonder about also just the influence of time and the resumption of more normal social activities, like what effects those things had as well on patients, just returning to the usual school environment or social activities with the loosening of the pandemic restrictions. Right? As patients became more active and, they were able to do other things, whether that also had an effect.
Tamara, Davide, that was a really fascinating discussion. It's great to hear where we've got to with this field. And thank you very much for your time today. You've been listening to the Neurology podcast with an update on functional tics. Thank you very much. Hello, and welcome to this podcast for Neurology. My name's Jon Stone. I'm a neurologist in Edinburgh and particularly interested in functional disorders and FND. And it's a great pleasure to be talking today to Tjerk Lagrand, who's a neurologist from Leiden. Tjerk, welcome to this podcast.
Thank you, John. Happy to be here.
So, Tjerk, you're the lead author in a paper that will be published online from January 2023. And it's a paper titled Healthcare Utilization in Functional Neurological Disorders, the Impact of Explaining the Diagnosis of Functional Seizures on Healthcare Costs. Now, that's a long title, but really what we're talking about today is whether explanation of FND and improving our skills in explanation can actually improve outcome for neurologists and maybe even save money. Is that right?
Yeah, that's right. I think the major takeaway of this study is that if we improve skills in the explanation of FND, we can improve outcome for patients and significantly reduce healthcare costs. But also that if we don't, and we don't give them an appropriate explanation of their type of seizures, it will cost the individual and or the healthcare system a lot of money. And hopefully we can have a good talk about that.
Tell us a bit more about yourself. Where did you carry out this study?
I carried out this study in Brisbane, Australia, when I was performing there a fellowship at Movement Disorder Clinic of Dr. Alex Len, also a movement disorder specialist and with a keen interest in FND patients. He's running a private clinic which is particularly specialized in FND. And there I performed this study.
It's a really difficult thing to study, is the effect of whether an explanation or what we do day to day actually makes a difference to patients. And I think you came up with a really novel way of looking at that. So just tell us a bit about how you did the study.
We identified 25 patients from an earlier study with video EEG proven functional seizures. And then we looked at the explanation that was given to them after the video EEG. And we defined the type of explanation, satisfying or unsatisfying, by a set of self-developed criteria. And we looked actually for 6 different things. We looked, they were given the diagnosis functional seizures. We looked at if there was something mentioned about an explanation of this diagnosis. For example, if something was written down about triggers or warning signs, those kind of things. We looked if they were provided with some self-reading or online material about FND. For example, some websites about FND. We looked if they were referred to a psychologist or a request to the GP to do this. We looked if there was a letter sent to the GP with the diagnosis afterwards. And the 6th thing is we looked if they had an appropriate follow-up. And that meant that they were seen for review back again within 6 months after the diagnosis by a neurologist.
And how did you define an unsatisfactory explanation versus a satisfactory one?
You could score 6 points max on the 6 items. And we thought, well, it shouldn't be a diagnosis given by an FND expert or something. Everybody could do it. And we thought, well, if the score was less than 3, so 0, 1 or 2 points, then we thought this is an unsatisfactory explanation. And in most of the cases, there were actually 0 points scored. So the patient wasn't given the diagnosis of FND, or there wasn't even a letter sent to a GP. And a score of 3 points or higher, that's what we found a satisfactory explanation. So I think not too difficult.
It's a relatively small study, isn't it? You only had 25 patients. And so I think it's important to say this is preliminary data, really, isn't it? But I think you ended up with, am I right in saying you ended up with 18 patients who did score more than 3 and so had a satisfactory explanation, and 7 who didn't.
Yeah.
So tell us about the difference between them then in terms of the effect that had on the costs.
In the group who received a satisfactory explanation, we saw that in a single patient that healthcare costs could be reduced from roughly $5,000 to less than $2,000. And in those 8 patients who received what we thought was an unsatisfactory explanation of FND, that led to an increase of roughly $5,000 to more than $20,000 in next year.
So it's a massive difference, isn't it, between those 2 groups?
Yeah.
And I think what's really fascinating about this is that you talk to most neurologists in the field of FND, and they're always saying how important that process of explaining a diagnosis is. I think we've all had an experience of it not going so well, or maybe, and hopefully most of us, an experience of it going well. It seems to matter, doesn't it? But it's been very hard to find good evidence for that. What had you come across before you did this study?
We found some evidence that a good explanation of FND could reduce healthcare utilization before. And we also found some studies about, the total cost of FND on the healthcare system. But actually, we didn't find any study earlier who looked at, well, all right, if you're doing a good job, that will probably save you money. But what if you're doing a bad job or give an unsatisfactory explanation? And I think that's one of the cool things in this study, that we also looked a little bit in what if you don't do it correctly.
Yeah, the studies I know, some of them have shown that patients use services less after they've been seen, had their diagnosis explained. But it's difficult to know, isn't it, whether that is related to the quality of the diagnosis or not. It might just be a generic, non-specific feature of just being in healthcare. So I think this does take us a bit further, actually, and thinking about a way of assessing the quality of that explanation. Can you tell us a bit about the limitations of this study? It is pretty small, isn't it? 25 patients.
As you mentioned earlier, it's a small group, but I think on the other hand, these were all patients with video EEG proven functional seizures. And I think that's the golden standard for diagnosing functional seizures at the moment. And other limitations, of course, it's a retrospective study. It would be difficult to do this prospectively, I think. And so we looked at the files of those patients. So we don't know exactly what kind of diagnosis was given to the patients. And also there are, of course, some confounding patient-related factors. For example, the time of the day received the explanation. Was it after hours in the ED department? Or those kind of things can also give some bias.
Well, for me, one of the most important confounding factors is perhaps that there might have been factors related to the patients who had a bad explanation that were independent of the explanation. So they may have been patients who were going to do badly for various reasons, particular comorbidities or other factors, and maybe that discouraged or somehow prevented a good explanation from happening. I'm being careful here because I don't want to blame the patient, but I think patient-related factors can interfere with the quality of the way that FND is delivered, I think. I think that's perhaps for me the largest criticism of this study.
Yeah, I think you're right.
For some years, I've been thinking about how one might do a randomized controlled trial of this kind of area, to try and prove whether good explanation is better than a bad one. It's really difficult to think about how to do that in an ethical way. Perhaps we can talk now a bit about the business of explanation, because it's something I've been thinking about for a very long time, over 2 decades. And you're now working as a neurologist in Leiden with an interest in FND. What's your experience of things that make a difference to patients when you're trying to explain FND to them?
First of all, give them the diagnosis. So it maybe sounds simple, but call FND FND and don't say something about the scan is normal or this is not an epileptic seizure. But no, this is a functional seizure, and explain them afterwards why you are making that specific diagnosis. Based on what factors? Based on, in this case, for example, the findings that you had from your video EEG. And then after that, I think, explain them a little bit about the pathophysiology of FND. And I don't think you have to be too scientific about it. But I often use the software versus hardware analogy from a computer. And I explain that something is going wrong in the software. And also, I think one of the things I learned is also do a proper follow-up in these patients. So it's not like, okay, I told them this is FND and now I don't want to see them again. But also after a couple of months, get them back for a proper review. Ask them if they, what they learned themselves about FND. Look what the effect of therapy is in those patients, and look if you can contribute anything more to them. I think those are important things for me when I deliver an FND diagnosis.
So it's really what you're describing there is really just normalizing this diagnosis, isn't it, in a way, and explaining it in the same way they would explain any other condition in neurology. And my impression is that we've often been doing something quite weird for these patients, telling them what they don't have or jumping to conclusions about the reason that they have the functional disorder. So I think you're describing a much more normal description in keeping with how one might explain to someone that they've got migraine or Parkinson's disease as well.
Exactly, and I think it shouldn't be different than explaining somebody who's having Parkinson's, explain them a little bit more about Parkinson's disease. Well, I think we should do the same thing for people with functional disorders.
And I guess one of the other things there is that you haven't talked about there, you didn't say we should tell the patient that we need to look for psychological factors and try and attempt to cure them that way, in what you've said there?
No, of course, sometimes psychological factors are important, but also part of a lot of other neurological diseases or diagnoses. So if in your consult with the patient if they say something about psychological factors, of course I ask them about it. But if they don't, then I sometimes also don't dig in too deep for those.
So it's about going carefully there, isn't it? For me, it's always rather like thinking about whether you ask someone if they're a smoker, if they've had a stroke. You would ask it, but not everyone has been, and you wouldn't necessarily be the first thing that you'd discuss. So that's been a really thought-provoking, and it gives everyone a list of 6 things as well to think about doing for their patients with FND to try and improve the quality. Just giving the diagnosis, making sure you've told the patient about it, maybe provided them some onward reading, a referral for treatment, a letter, follow-up. These are all very straightforward things, aren't they, to get a satisfactory explanation. And hopefully those things can reduce healthcare costs and, more importantly, improve our patients' conditions as well in the longer term.
Exactly. And add one more thing that we saw in this study is that it didn't differ between, for example, neurologist and registrar. They were equally good in delivering an explanation. So, I think almost everyone can do it in a normal way, as you do with other neurological diseases.
Great. Yeah, it just shows it's very much a team activity. Okay, well, thank you very much for speaking to us today, Tjerk. I hope people enjoy reading that paper coming out shortly in Neurology and Clinical Practice. Many thanks.
Yes, I hope so. Thank you for the interview.
Welcome to this episode of the Neurology podcast. My name's Jon Stone. I'm a neurologist from Edinburgh, and I'm really pleased to be doing another podcast on FND. I've got with me Mahinda Yogarajah from University College London. Mahinda, maybe I can just ask you to introduce yourself first.
Thank you, Jon. My name is Mahinda Yogarajah. I am a clinician scientist based at the National Hospital for Neurology and Neurosurgery in UCL in London. So as a clinician, I have particular interest in epilepsy, FND, and seizure-related disorders. And I also run a research program into patients with FND, particularly functional seizures.
Great. And we're talking today about a paper that's coming out in Neurology very soon. It's called The Economic Cost of Functional Neurological Disorders, a Systematic Review. Mahinda, why did you choose to study health economics in FND?
I think the science has got to a point where we have a much better understanding of the how and the why where functional neurological disorders are concerned. And that really makes a compelling moral argument that we should be investing more in clinical and academic pathways. But by and large, at least in the UK where I'm based, these pathways don't really exist in the same way they do for other chronic neurological disorders. So given that there's a moral imperative there, we wanted to build a robust economic argument for why people should be investing in these pathways. And, we thought this would be useful to the community at large, but also our own efforts, which is we try to build better clinical pathways.
So you did a systematic review looking around the literature to see what we know about costs and what we don't know. What are the headlines here from your study?
The headlines, bearing in mind there are obviously limitations in the data that's out there, but I guess you could sort of group the studies into sort of 3 basic groups. There are studies that have taken patients with FND and tried to calculate the costs associated with that diagnosis. Then there are groups of studies that have done the same thing, but have compared the cost of FND to other chronic neurological disorders. And finally, there are a small number of studies that have attempted to compare costs before and after an intervention, and also some of those have attempted to assess the cost effectiveness of that intervention. So if we take the second group, so that's looking at FND patients to other patients with chronic neurological disorders, what these studies show, an example is a study by Stephen et al., which we talk about in the review. If you look at those costs, they are pretty similar, if not in excess, of those other patients with chronic neurological disorders. So if you take the Stephen et al. Paper, that was based in the USA, large study. They found an annual cost for an adult with FND is about $62,000. While for a child with that diagnosis, it would be $28,000. And those costs were comparable to patients with refractory epilepsy or demyelinating diseases or anterior horn cell diseases. And there was only one European study comparing costs of FND to another group. But again, the costs were not dissimilar. So they found an annual direct and indirect cost for a patient was about 41,000 euros. And their control group there were healthy individuals where they had a cost of about €10,000.
So we're spending a lot of money on FND. And I think the numbers, I mean, that's per patient per year, which is really helpful. But how do the numbers stack up across a country, for example?
The numbers obviously increase exponentially, so the numbers stack up in a big way. So you talk about millions and millions of dollars or pounds or euros being spent. And if anything, when you look at these studies, these are underestimates for sure, because to give you an example, the paper I just mentioned, that focused on inpatient admissions. It didn't include outpatient clinics or outpatient diagnostics. That will add to that cost associated with FND. And similarly, there are indirect costs. And many of the studies that we looked at didn't factor the indirect costs. So these are costs related to loss of employment, benefits, carers having to take time off work to look after patients. And again, these costs should be included and they would add to the figures that I've quoted you. And then finally, of course, there are intangible costs, which are difficult to quantify. These relate to the sort of social, emotional and human cost of these disorders.
So I was very struck by, in the paper, that you quote that Stephen et al. Paper, that the total cost, I think, just of inpatient admission was 1.2 billion for people with FND, just over a 1 year period, which is really incredible, isn't it?
Yeah, I mean, these are huge, huge figures we're talking about.
And you mentioned there the studies that were trying to look at cost effectiveness, which of course is a much harder thing to do. What did you find there?
You're absolutely right, John. This is a much harder thing to look at. So a variety of studies did attempt to look at interventions and how cost effective those interventions are. Many actually focused on simply making and communicating a clear diagnosis. Several, for example, focused on the use of video telemetry in making a diagnosis of functional seizures. And these studies showed that there was a reduction in the cost from anywhere between 40 to sort of 86% in the 6 to 12 months before the diagnosis compared to the same at the time after making a diagnosis. And this is interesting because it kind of tallies with more recent publications that were too new for us to include in the systematic review. For example, there's that really nice Neurology clinical practice paper from Alex Lenz's group in Australia showing that VT and a good and clear communication of a diagnosis reduces costs significantly in the 2 years after making a diagnosis. But then, of course, there were a smaller number of studies that looked at specific interventions, and they tried to answer the question of essentially how cost-effective a treatment is by combining the costs of those treatments and comparing them to improved clinical parameters such as QALYs or quality-adjusted life years. So what they're trying to do in these studies is quantify the impact of the patient's condition on the quality and quantity of life lived. So there are problems with these studies, which we can sort of go into a bit more detail of. But essentially what these studies showed, by and large, was that you could reduce costs and increase QALYs, especially compared to standard medical treatment, using these interventions. But things become a little bit more tricky when you're trying to assess the cost effectiveness because, for example, you have a threshold for the cost per QALY, which we, for example, have the NHS with things like NICE guidance. And there, things become a little bit more problematic because I think functional neurological disorders and patients with FND are much more complicated than many other disorders where you'd be assessing cost effectiveness.
Did we find evidence of cost effectiveness from the studies that we have on these intervention studies?
If you look at the intervention studies, many of them were from the UK. One of them was based on physiotherapy for patients with functional movement disorders. And if you take the threshold for the cost per QALY as defined by NICE in the UK, that would be defined as cost effective. There were 2 studies looking at the cost effectiveness of essentially CBT for patients with functional disorders or functional seizures. And one of those, again, if you take the criteria or threshold defined by NICE in the UK, would have met that threshold and the other wouldn't have met that threshold. But I think it's important to take a very sort of nuanced approach to these studies and what sort of figures they're reporting. Because as I said, I think there are broader issues when you're trying to work out the cost effectiveness of treatments for patients with FND.
Because one of those trials was the CODES trial, wasn't it? Which I have to confess I was involved with. So I'm a bit biased. But that economic evaluation was based on the fact that seizure frequency didn't change very much in the patients who got added CBT, but actually on lots of other measures, the secondary outcomes, they did much better, arguably more important secondary measures like what they were doing in their work and life and whether the seizures bothered them and that sort of thing.
As I said earlier, I think this sort of speaks to the idea that there is lots of sort of things you have to sort of think about carefully when trying to design studies to look at the cost effectiveness of treatments in FND. So we know, for example, FND is a very heterogeneous condition and patients have a significant amount of variability, not just in the nature of their symptoms, but also their comorbidities. So this then makes it difficult not just to gather quality or high quality cost effectiveness data, but it also makes it difficult when you're trying to sort of generalize findings across different patient groups. And if you have a treatment approach based primarily on the presenting symptom, so you mentioned the CODE study, so if you're just focusing on seizures, but you don't think about or consider the other comorbid problems, you're going to dilute or even obscure your treatment benefit for a subset of patients. And that then is going to have a knock-on effect when you try to quantify the cost effectiveness of the intervention. I mean, that's just one example of an issue. Other issues, for example, outcome measurements, which also applies to the CODE study that you mentioned. So we know you have to think carefully when you're trying to work out what are the outcomes one should be using when you're trying to decide whether something is effective as a treatment, and similarly, whether that treatment is cost effective. So I think if you think about functional seizures in the same way we might think about epileptic drugs and epileptic seizures, I think there are problems there. And that's maybe one of the problems with the CODE study in terms of assessing that cost effectiveness of that intervention. And then equally, interventions themselves are complicated. They're often MDT based, they're complex. So again, this needs to be thought about carefully when you're assessing the cost effectiveness. And finally, I would say, we know that FND is a chronic disorder. It's a fluctuating disorder. You really need long-term data here. You need long-term studies to get a true picture of how you might reduce costs over the long term, and similarly the durability and sustainability of the interventions in question.
So we're spending a huge amount of money on FND, whether people want to or not, they're spending it. We know that the cost effectiveness is a bit harder. Do you think we can use this data to argue for better services for FND? Or do we need the economic arguments to do better?
I think the data from the review makes a compelling argument at one level that we should be investing in clinical pathways and academic pathways for these patients. So by showing that these disorders have comparable costs, perhaps costs in excess of those of other chronic neurological disorders, I think that's a pretty compelling economic argument to invest in those pathways. Beyond that, if you're talking about how do we sort of develop cost-effective treatments, well, I think you have to do the research to sort of prove that something's cost-effective. But equally, when you're doing that research, I think you need to be aware of the complexities of these patients and the treatments we use in these patients when deciding whether something's cost-effective. So I think the paper overall says, yeah, we should be investing more money clinically and academically in this disorder and in these patients.
And the point is, we're spending the money anyway. You know, if one appreciates just how much money we're spending, well, we might as well spend it properly, or at least do something that's useful for patients, rather than what they often get is huge numbers of investigations that perhaps they don't need.
Absolutely. They often, as you've rightly pointed out, will go around in circles because there are no clear pathways. So they just end up going to different healthcare providers, never getting a clear communication of an effective a diagnosis, and therefore not getting referred on for appropriate treatment. I think the earlier we do that, better for the patient prognostically, but also, the more economically efficient for our healthcare systems.
Something I was interested in, because this is the second time I've done a podcast about an economics paper for neurology. Do you think people look at this issue a bit differently in FND to other neurological conditions? Do you think there's a need to justify seeing patients with FND that we wouldn't feel quite the same about with MS or epilepsy, for example?
I think there's some truth in that. I think there's still, despite all the amazing advances in research and the things that are being published increasingly in the last few years, there's still stigma attached to these disorders and these patients. And I think because of that, people at some level, some people may implicitly not see it as real, or some way maybe say, feel the individual's responsible for their condition, and therefore think there should be no cost associated with these disorders. But obviously the disorders are clearly real, and there is always going to be a cost associated with them. And I guess we're not suggesting with this paper that cost should be zero, but we're saying actually, in the first instance, doing very simple things like clearly defined pathways and early effective communication of a robust diagnosis can reduce those costs.
Well, thanks very much, Mahinda, for that. I think it's a really important paper. It summarizes just what a massive economic impact FND has on health services, and something that we really need to think about. So the article's called Economic Cost of FND, a Systematic Review. It's coming out in Neurology in mid-2023. And you've been listening to me, Jon Stone from Edinburgh, and Mahinda Yogarajah from London. Many thanks.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.